Hi, I'm Sheena Gill. Welcome to Early Detect Studios. Today we have our very own CEO, Venkata Peri, in conversation with the nation's leading voice on maternal and infant health. PV co-founded CognitiveCare as a primary conduit for the early detection of diseases, health risks, and outcomes, with a significant focus on maternal and infant health. In this light, today we have an exciting fireside chat between PV and Dr. Rahul Gupta, Senior Vice President, Chief Medical and Health Officer for none other than the March of Dimes. This exciting conversation has many important and interrelated topics, including the troubling maternal and infant morbidity and mortality rates in the United States, predicting future outcomes through data, analytics, computational sciences, AI and ML, and deep learning, COVID, social and lifestyle determinants in maternal health, and how the March of Dimes is and will continue to lead the movement to fight for the health of all moms and all babies. So let's get started.
Good morning, Rahul. Welcome to the Early Detect Studios. I'm so glad that you were able to make it. And the purpose of this conversation is really to understand your perspectives on maternal infant mortality and morbidity. And from a three-dimensional point of view, what is the contemporary research going on in maternal infant mortality? Second, how we can bring new technologies, especially around artificial intelligence and deep learning, to understand the disease and the symptoms early. And finally, how we can move the levers of public policy, working with the state, local, federal governments to ensure that these insights are delivered. So, to that end, your role as a senior vice president and chief medical officer at March of Dimes, the institution that has given so much to the communities in reducing infant mortality and morbidity, maternal mortality and morbidity. And I think your perspectives are extremely priceless for somebody like us who is really working on maternal infant mortality and its reduction. So, with that said, a few comments from you, and then I'll go through a discussion in terms of a few questions, and if you can share the perspectives, that will be very appreciated.
Wonderful, and thanks for having me on, TV, and thanks to your team. It's very important that we begin to talk and continue to urge, everywhere and anywhere we can, to the importance of this particular topic, which is the relative importance of maternal and infant health across the globe, and in particular within the United States, why it's important, and as you mentioned, what can we do to work as a catalyst to move things forward in a meaningful way so we can start to experience the progress that we must make in order to not only have better outcomes but really to secure the future of United States as well as for other nations across the globe and become a leader in maternal infant health crisis that is ongoing, as a way to bring solutions to the table. Thank you for having me.
Thank you, Rahul. And the fault lines in healthcare have been visible for a while, especially around the disproportionate impact on certain communities. And our inability to detect some of these symptoms very early, and a very pigeonholed episodic treatment paradigm, if you will. And these fault lines have been visible, and COVID has only accelerated and demonstrated to us that it is very, very important to detect these fault lines before they genuinely become earthquakes. And be able to proactively detect some of these outcomes. That's what COVID has taught us. Now, how do you see maternal and infant health crisis in this particular context of disproportionate impact on certain segments of the community, inability to detect some of these symptoms early, and be able to reach out to the communities proactively with the right kind of interventions?
So it's been very important to, while looking at the global pandemic that has affected just about everybody across the globe. So unless you are living literally in a forest, you have been impacted. The fact of the matter is that there are some populations which have been impacted more than others, and this stands true for the United States. It stands true for the rest of the world. Martin Times, even before COVID, was working really to understand from a scientific research standpoint, from developing those strategic partnerships and making and influencing, helping influence those key policy decisions, as well as providing number of programs to help move the needle forward. What this pandemic did was just encourage all of us to accelerate our efforts. It's very important that when we start to learn about the disproportionate impact on populations, one of the things that comes to mind is it has only unveiled, it's helped us look under the hood of what's happening as an example in US context. So for instance, we've seen the outcomes for African American, outcomes for American Indian, Native Alaskan people, as well as for Latinx people, overall be poor, relatively speaking, during pandemic. While it is nowhere more true than it is in the case of maternal infant health. Whether we talk about lockdowns, we talk about quarantine, we talk about access to care, this has all impacted people who were pregnant, or thinking about becoming pregnant, or thinking about delivering. There's been a significant disruption in the way people have thought about. Generally, as you know, it's very important to have that relationship for 9 months with your provider. But oftentimes we've seen where people had to travel somewhere where they can actually be with their family and their spouse during labor and delivery. Those type of disruptions do have a cost in terms of healthcare. It also has the pandemic has unveiled the issue of financial stability, meaning and health insurance status. Lots of Americans have lost their health care coverage. And then there's a lot of frontline workers who often had to think between taking the risk of getting COVID while working versus putting food on the table through a job and the fear of losing the job. So those things have just unveiled the systemic racism and the wealth gap that continues to deepen, which really results in significant health inequities in our society that are really not fair. And that's the work that's ahead of us to ensure that we have systems of care that includes using artificial intelligence to develop some ability to figure out who is higher impacted versus not, and then to focus our attention on those individuals so we can have better outcomes.
Indeed, indeed. That's very well said. And the impact is very, very visible from across multiple dimensions on the people who need the care the most. And often they're the ones who are in the firing line. Now, moving in terms of moving to the United States in particular, US is one of the developed countries where the infant and maternal mortality is actually increasing year on year. Do you foresee that this is indeed a crisis? Maternal infant health is a crisis in the United States that really requires immediate attention. And if it is indeed a crisis, what, in your opinion, are some of the underlying reasons or causes? You outlined a few, but if you could put that in perspective for us.
Sure. So, PV, it's very clear and apparent to us and to many of the policymakers in the United States that there is a maternal infant health crisis ongoing within the United States. For instance, there's a death that happens as a result of childbirth every 12 hours around the clock. We are one of the countries, the developed nations, with some of the highest rates of maternal mortality and morbidity across the globe. Um, we know this is a problem. We know this is a challenge. We know we've had at least 2 decades of rising numbers, whether it's more case detection or actual increases or both. But the fact of the matter is we have a problem. Um, that's maternal health, maternal mortality. We also have about 50,000 near death experiences, or what we call severe maternal morbidity, that happens each year as well in the United States. Now, when you look at that and you look at who is it impacting, We know that if you're black in the United States, your likelihood of dying as a consequence of childbirth is 3 to 4 times higher. That is unacceptable. We also know from an infant side of this that we have fifth year in a row rising rates of preterm birth, and preterm is one of the uh, leading causes of infant mortality. So that's another issue that we have. We already have about 22,000 babies that die each year before reaching their first birthday in the United States. Now, if you compare to a century ago, we made significant improvements. If you compare to where we are in 21st century, should we have 22,000 babies dying each year before they reach their first birthday? Perhaps not. And so we have work to do. But once again, when you look at just the fact if you are a black woman in the United States, your likelihood to give birth to a preterm child is 50% higher than if you're a white person. So these are the differences. And I think, as I attempting to mention, the causes behind this maternal infant health crisis are multifaceted and complex. So they can be tracked back to inequities in our society. They can be tracked back to systemic and structural issues, access to quality health care, social determinants of health, including socioeconomic status, education, housing, things like access to clean air and water, food insecurity, as well as racism and implicit bias. We believe high quality professional workforce, like having doulas and midwives, is also important, and lack of that is also playing a role. So we believe that we also have to have policies like paid family leave that allow our system to strengthen so people don't have to worry about losing a job or not having enough accommodations in their employment when they become pregnant. So these are all some of the non-medical aspects, but there are clearly aspects of medical care that could be improved as well.
Great. I mean, this is so eye-opening and revealing. If you look at it in terms of the impact of not having the right facility, the right doctor, the right resources taking care of the mothers, and how that could impact the childbirth, even if the child were to survive the birth, and how the future health of the child is impacted in terms of both the health and the well-being of the child and the mother, but also the larger impact on the consumption of resources, healthcare resources, which is a huge problem as we understand. Now, let me pivot a little bit towards the science and research that you undertake to understand the causes maternal infant mortality and maternal infant morbidity. If you could throw some light on the underlying science, the scientific research, the medicine, the biology that is driving some of these imperatives over the next few years. A few perspectives on that would be really eye-opening for us.
Sure, thank you. Priya. I think it's very important that we continue to approach this in an evidence-based, science and data-driven manner. So when we start to look at the mortality, the morbidity, meaning the deaths and the suffering of pregnant people, and use that as an example of upstream as well as downstream challenges. One of the things we see, and this has been pretty well reported by the Centers for Disease Control and Prevention, is you can really use the rule of third. So where are these deaths occurring? A third approximately are during pregnancy, a third during childbirth, and a third of them are between 1 week to 1 year postpartum. It's important to understand that because that should help us drive policy in that direction as well. Then you ask yourself the question, why is that happening? Well, oftentimes there are conditions within for the mother to be, things like having preeclampsia, overweight and the consequences of such, like diabetes, uncontrolled, and other challenges that go on, and just access to care and making sure that there's all those prenatal conditions are being met. Then, of course, during labor and delivery, you're looking at issues of like postpartum sepsis, hemorrhage. Oftentimes, that whether there's an appropriate when cesarean section is done, are there other consequences that happen as as a result of the childbirth? And then a consequence of preeclampsia also come in. And then postpartum, really, you're looking at not only those conditions that I mentioned and the consequence of that, but also you're looking at mental health situations. You're looking at
Indeed.
substance use situations. And none of these conditions just stop after delivery. That used to be a myth that once your child is delivered, perhaps preeclampsia goes away. Perhaps gestational diabetes will just go away and never come back. But those are not the situations. So when we look at the causes, those are some of the causes. We also know that it's important to understand. For example, we've done some research to look at, you know, if you work shift, meaning at nights versus days, does that influence your ability to have a preterm child? So we're the same way it goes with the ability to have paid family leave and long-term impact to employers on that. So we have looked at some policies. We have looked at some of the medical literature and medical reasons for it. At the end of the day, we have to take a comprehensive approach, encompassing the science as well as those social determinants, what we call social science, and factor in and make sure that we're looking at mortality as well as the morbidity. Because if you think about the iceberg, think about the tip of the iceberg and the remaining underneath. And you can have a large underneath of the iceberg, and that's where the severe maternal morbidity or near death experiences are, which are about, as I mentioned, about 50,000 people that suffer through those near death experiences each year in the United States.
Excellent. I mean, that is, again, as you share these statistics, they open our eyes so much that, the crux of this to solve the problem is really the three pillars, as they call it. One, the classic science, which is medicine and biology. And the second one is really our ability to bring together advanced technologies to understand medicine and biology in great detail. And finally, to convert all of these insights into policy interventions. I think that is very well said. Now, let me again shift the gears a little bit, Rahul, and again gather your perspective as to how important do you feel is the early detection of these risks during pregnancy, or even, dare I say, even pre pregnancy? For example, do you think that it is really, really helpful and insightful to detect a birthing person who would have high risk of, let's say, postpartum hemorrhage or a postpartum depression, or an infant with a risk of a congenital disease or gestational diabetes? So, how important it is, both as a practitioner as well as a policymaker, to be able to detect these outcomes very early in the pregnancy cycle, or even, as I said, in the pre pregnancy?
I think that's a good question, Piri. And so let me paint the picture a little bit. So we have a modest understanding of these conditions that lead to poor outcomes, both for the mom as well as for the baby. So when we look at things like economic security, structural and environmental inequities like housing, transportation, food insecurity, pollution, and other things, these are things that can be captured, that can be looked at and assessed, even in a clinical context. And then we have clinical aspects, right? So we have things like stress, depression, addiction, trauma, anxiety. We also have chronic health conditions, cardiovascular conditions like cardiomyopathy and heart conditions, hypertension disorders, including preeclampsia, diabetes, obesity, nutrition. Reason I say all these things because about 2/3 of American adults have at least one of the chronic conditions. Why is that important? Well, let's walk this through to answer your question. People were just dying on the streets in the 1960s and 70s of heart attacks. We were really afraid. We did not know, and I'm using this as a corollary, what happens. So we took on some data and studies like the Framingham Heart Study to really analyze and understand and risk stratify who are the groups of people who are more likely to have a heart attack as opposed to the general population. And we did a great job understanding that. And today, when you go into your private practitioner's office, your clinician's office, they will ask you a certain amount of questions that include your cholesterol levels, your smoking status, your age, family history, diabetes, and other things, because it helps them stratify people into high risk. And we have shown that if you can address that population, we've seen a tremendous decline in heart mortality and morbidity. Why I give you that example is that's exactly what we need to be doing for maternal and infant health. We have to figure out a system that helps us better risk stratify. Because the fact of the matter is, there's no amount of money and policies in the United States or across the globe that we can provide everything to everyone who's pregnant. We have to be able to become smart about this. And part of being smart is to understand who are the people, and this goes through the lifespan of pregnancy and life course of an individual, who are at higher risk as opposed to average risk. And then we have to focus on those individuals for those outcomes to, what we call modifiable risk factors, to change those risk factors, as opposed to the non-modifiable, which are like age, your race and things like that. So I think if we can figure out through artificial intelligence, data tracking, and capturing enough of that information in medical records to understand the high risk people, that is the beginning of an effort to actually impact the maternal and infant health crisis in an informed, data driven way. And that's what we need to be sort of encouraging, because if we start there, then what is it going to mean? It's going to mean that we are enacting and implementing the right policies, the right interventions at community and individual levels, and it's then helping us reduce the preterm birth, reduce birth defects, improve the environment of the people who are pregnant, and ultimately reduce that third and third and third poor outcomes of pregnancy. So it's going to have a disproportionate impact both on the mom, baby, but especially with a lens of equity. And that's where we need to be.
Excellent. Again, terrific perspective about the importance of bringing um, detection capabilities. I'm using the word detection in a very generic sense here, which brings me to the next question. So, for example, the evolution of computing capabilities, Rahul, as you know more than anybody else, has been at a lightning speed in terms of our ability to really mine very large volumes of data, even address problems around data anomalies and missing data values, and our ability to bring together very disparate sources of data. For example, I can look at the health records, I can look at claims and prescriptions, I can bring the radiological determinants of the birthing person, the ultrasound images. I can look at the genetic data from the birthing person, and I can put all of this together and try to understand historically, number one, as to why certain things have happened in a certain way, and then put on the top of it a predictive capability that's a combination of what I call as mathematics, statistics, and more recently, the manifestations of artificial intelligence and deep learning. And so you said you addressed that in a very elegant way. So again, I just want to reconfirm that you, as a senior practitioner and a public policy influencer, do feel that this intersection is very, very critical to be able to detect this mortality and morbidity signs early.
Maybe I think it's not only critical, but it's the call of the time. I mean, if you look at it before, we started the field of medicine became really evidence based when we started to do case studies, and then we would put few cases together. We would go to a conference. I'm talking 100 years ago, and we would present our case. People would critique that, and then we would maybe publish it. But we were in other ways using the analog system of health systems. Today in the 21st century, I think not only is it a calling, but I think it would be unfortunate if we cannot put data and technology to good use to help in real time save lives. This is what this is ultimately all about. This is about saving lives. And we have the technology today to be able to put it to use for medicine, for the improvement of health for everyone across the globe, especially in this space that is such an urgent crisis. So I think we can, we've seen during the pandemic, we were proud in 1955 when we developed the first polio vaccine, or we helped develop, funded the first polio vaccine within a matter of years. We said at the time it was a lightning speed. We're talking 3 to 5 years is lightning speed to develop a vaccine, because that was the call of the time. Today, you fast forward by just about 65 years or so, and We've seen in months vaccines, not one, but multiple vaccines from across the globe developed on various different platforms. That's the use of technology, and these seem to be very effective and safe vaccines. Why can we not utilize technology to improve and help save lives today in maternal infant health crisis? So I would almost say that, the job is not done in just collecting data and conducting surveillance. We have the wherewithal today to utilize artificial intelligence and computing to impact people's lives in real time. And we hope and we want to be able to choose to do it. So it's imagine flying a very expensive aircraft to the eye of a hurricane to take measurements and coming back just knowing how strong the hit will be, but not knowing where the hurricane is headed. That's how it's going to feel to have surveillance without artificial intelligence. So it's critical for us to understand the issue, learn the issue, but also to have impact on real people's lives and save those lives.
Indeed, indeed. Very, very well said. Thank you, Rahul, for that. Now, you addressed it briefly. My next question is about, in particular, about the relevance of social and lifestyle determinants in predicting the outcomes. Often we know that clinical determinants, radiological determinants, genetic determinants, they already been a part of this whole detection mechanism, understanding the disease and the symptoms. But of late, we have realized that social lifestyle determinants are very, very important, and that these are no longer social problems; these are actually problems of science. You did allude to that very briefly. Again, if you could elaborate on that perspective as to, from your vantage point, how important the social lifestyle determinants in understanding and reducing maternal infant mortality and morbidity.
So, we have had data since the, almost the late 70s, early 80s to give us a little bit of heads up as, hey, what is happening in the four walls of a doctor's office or a hospital may not be telling you the real story. And now, through science, we've learned that um, medical care only dictates about between 10 and 20% of your health. So there's a difference between medical care and your health. And we also know that the health of an individual is really determined by where in the community, where they're born, where they're raised, where they worship, where they work, where they play, and what their community is like. Those are all the conditions that seem to have a disproportionate amount of influence on your health. So if you think about it, if you're healthy and you follow the rules, you may be going to a doctor's office, 15 minutes visit a couple of times a year. That is 30 minutes that you get to see your doctor in 365 days. Well, what happens for the 364 days, 23 hours, and 30 minutes, the remainder of that time? Well, you're in those communities with your family. You are worried about your job. You're worried about your transportation, your food security, housing, physical security, your behaviors, environment. All those factors, it turns out, have a so much more greater influence than just the four walls of a hospital or a physician's office. And so these are what we call social determinants of health. And what we're learning is there are systemic inequities, including systemic racism, that occurs within those communities that causes the outcomes to be so differential for different populations. And that's where we need to be, following up and focusing on. And these 21st century tools, such as deep learning and artificial intelligence, can help us point towards those inequities and address them and really put resources behind those areas in a way that we've never done before. So these are the, ability for us to focus on what matters is critical. For example, in 2020, we produced Nowhere to Go, Maternity Care Desert Across the U.S. Report 2.0. We showed that about half of the counties in the United States, literally half of the counties, just like food deserts, are living in maternity care deserts, meaning 7 million of women of childbearing age live where there's no or limited access to maternity care. So this is the kind of data that we need to use to make better decisions. So that's why we've been pushing for changes in access and prevention in equity to be able to have the impact we need in order to address these social determinants of health.
Great perspectives. And again, with every answer of yours, I'm only looking at the statistics and realizing how much more work to do, but also very encouraged by the fact that, as you rightly pointed out, we have the tools and the wherewithal to be able to not only understand the genesis of the problem, but be able to convert these insights that we generate both at a personalized treatment level and also be able to go out and look at the aggregated trends in the communities and how we can inject ourselves to be able to bring those necessary changes. So, which brings me to the next question, Rahul, again from your vantage point, which is very unique. You are a physician, both by training and practice. You are an academician, you do teach students, and then you are a public policy expert. So, across states and at the federal level, you have had the opportunity to understand these problems very effectively and be able to work with the elected officials and the nominated officials to come up with the right strategic policy reviews and interventions. So, what should be some of the best practices to work with a very cross section and sometimes conflicting priorities of these stakeholders in the healthcare in general, maternal infant health in particular? Some best practices as to how we can ensure that these insights are converted into right policy interventions.
Maybe I think it's a good point to make, which is here's a problem, here's data, and now let's talk about solutions. So when we think about solutions, I think having first and foremost an ability in real time to be able to risk stratify people at high risk is important. It's a critical tool in the hands of the practitioner. I would, as a practitioner, love to know which of my patients are more likely at risk of having poor outcomes so I can intervene and also be held accountable at the same time. So that's a very important tool, and we continue to advocate for such policies. Now, in addition to that, there are certain policy impacts. For example, we know that expansion of access to care through coverage, like Medicaid expansion, is a critical tool. If more people have coverage, then they're more likely to get early good care. Understanding that almost half of the pregnancies in the United States are unintended to begin with. So we already are running, our starting line is behind already. So we have to get people as early as they find out they're pregnant into healthcare because it's a race against time when you're pregnant. The second piece is postpartum coverage. Oftentimes about half of the population's pregnant population in the United States is covered through Medicaid. It's a public insurance program. But what happens is, oftentimes you're kicked off of Medicaid at 60 days postpartum. So we're really encouraging states to consider expanding that to at least 1 year. Why? Well, because if you're suffering from diabetes or high blood pressure or substance use or mental health condition like depression, it doesn't magically disappear at 60 days. There's nothing magical about it. What we need is to provide the help to the individual and help them get back up. And 1 year is at least the amount of time somebody can get the help that they need. So these are the kind of policies that we think, same way with workforce. We think when we talk about maternity care deserts, we really want to see an expansion of the appropriately reimbursed ability to have culturally sensitive workforce in terms of doula care, in terms of midwives. We believe physician-led teams that have these components within that team can help create a bridge across maternity care deserts. So no one feels, if you're someone that's living in maternity care desert today in the United States, which is about half the counties we talked about, every time you have to do a prenatal care visit, think about this. You have to take your time off from work. You have to find daycare for your other children. You have to find a way to be transported or, gas money pretty much to go out of your county to get somewhere. Then you have to wait in line and sit. And then you have to wonder if you have the ability to have the copay for the recommendations that were prescribed in terms of medication and other things. it becomes very difficult during pregnancy to deal with everything else and this one more thing now. So this is the kind of thing we want care to come to people as opposed to people going to the place of care ultimately. These are some of the policies that will help us address social determinants of health. They will help us address some of the social issues, as well as create a more a just society across the United States.
Excellent. I mean, this is again very insightful that there are stakeholders at various levels within the communities. As you rightly said, the individual herself is a key stakeholder here, the most important person. And then, in addition to that, what we are looking at is the governments at multiple layers, all the way from the local to the state to the federal government. And of course, we're looking at the employers. You're looking at the rest of the healthcare ecosystem that has to pitch in to be able to again identify these challenges, to play their part using all these different insights to be able to detect, prevent the maternal infant mortality and the morbidity, if you will. I have another classic doubt around specific outcomes, Rahul, and I'll focus this on specifically around C-sections, etc. What happens is that we know that CDC and other agencies have said that two-thirds of C-sections are avoidable, and and again, early detection should be able to give us a lot of insights around this preventable C-sections, if you will. What is your perspective as to how important it is to address some of those things, not only just from avoiding C-section point of view, but also trying to reduce the overall morbidity and the subsequent symptoms of long-term health of the babies and the mother?
I'm glad you brought that up, PV, because one of the things that we know has been said before is when we talk about this tip of the iceberg in terms of a person dying every 12 hours around the clock as a result of childbirth, we also know that 60% of those deaths are preventable. That's a huge number. If we knew how to prevent 60% of deaths and potentially the morbidity that goes behind it, also the 50,000, that we should be racing towards solving that problem because those are lives that could be prevented and saved today. So, and that same goes for C-sections. That if there are C-sections that can be prevented, because remember, when someone especially gets a C-section for the first time, the likelihood for their second and third birth that they will also get a follow-up C-section becomes quite high. And that also means that potential outcomes could become poor as well. That likelihood goes up as well. So if we have the opportunity, and I will contest to you that we do, to change these outcomes, to start to work on that 60% prevention of mortality and perhaps morbidity, we should. Whether it's C-sections, whether it's other set of healthcare conditions like high blood pressure, diabetes, obesity, substance use, and whether it's overall mortality and morbidity. We should not shy away from it. We should begin that work, and that's indeed what we are hoping to do. Accelerate the progress. One of the things at March of Dimes is that we are saying that, listen, we can't wait. We cannot, those women who have died cannot come back. And one of the worst things that happens is you have a baby without the mother. So we're encouraging both our advocates, policymakers, practitioners, as well as the people out there to become our advocates and grassroots to say, we cannot wait for one day when we can achieve our goal of preventing those 60%. We need to do that today. So we're working pretty much as a catalyst in the system to move things forward quicker because lives are at stake here.
Indeed, very touching and extremely inspiring and insightful. And finally, Rahul, the question about March of Dimes and how you are steering March of Dimes towards becoming an interdisciplinary research institution that puts together, deep learning, artificial intelligence at the intersection, as I would call it, at the intersection of medicine, biology, and multiomics. And Where do you see? I mean, today we see the footprints of March of Dimes in every baby of the world, Apgar score or otherwise. So, where do you see March of Dimes moving ahead, and what is March of Dimes 2.0, and what can we expect in the next 3 to 5 years from March of Dimes and its body of work?
Well, I can tell you this, that we have a wonderful team of leaders at March Dimes, led by our president, Stacey Stewart. And we envision a model of care, pregnancy, and postpartum to become much more data driven, much more technology friendly. But we also understand that data will not only get collected during doctors' or hospital stays or doctor visits, but also in real time. And the day to day of the pregnancy, with the help of potentially, I mean, when you look in the future, we could potentially look at home monitoring technologies that are now happening with, diabetes and blood pressure can go beyond. So we have to adopt sensible technologies moving forward, but also understand that this data alone will not answer our toughest questions. We have to use data to get smarter, and that's where AI comes in. We have to be able to use data to tell us where there isn't enough data, and we need to get started where we need more of it. But we also need to know what's the right direction through AI, who are the people, where are the biological processes, and how quickly can we begin to move both our policy and practice in order to save lives. So I think the deep learning systems, artificial intelligence, and overall data is going to be core to the future of good practice and impacting maternal infant health crisis with a lens of equity. And that's exactly what March of Dimes is focused on. We've in the past we've led the work for polio vaccine. We pretty much helped develop a model of micro fundraising through our walks and other aspects. We've led a lot of work in terms of birth defects, folic acid, preterm birth, both science, service, as well as policy. But it's now time to, we understand it's time to adopt data, adopt technology, and help accelerate the progress that we need to happen, because it is a crisis, a true crisis, and we need to be doing everything we can today, all of us together, with our colleagues and partners across the globe and within the United States to move forward.
Thank you. Thank you so very much, Rahul. This has been one of the most insightful sessions for me personally. And as maternal infant health is one of the core focus areas of what we do. And as I often tell my team, that eradicating maternal mortality is the mission, the purpose with which we are being driven at Cognitive Care. And these priceless lessons and priceless perspectives from you as the Chief Medical Officer at March of Dimes, driving a whole gamut of activities from research to partnerships to collaborations, is critical for our own understanding and coming up with solutions and artifacts to help the larger communities of physicians, payers, and the patients themselves to be able to enjoy and navigate the journey, the priceless journey of motherhood very, very well. And all of us at Cognitive Care, I take this opportunity to express my sincere gratitude to you, Rahul, for sharing your wisdom, for your time, and of course answering all these questions so very patiently. Thank you very much, and stay safe and stay well.
Thank you very much, and thank you for all the work you're doing.
Thank you very much. Take care, Rahul. Bye.